Reliability of motion palpation findings. Chiropractors and others who utilize manual therapy rely on physical findings to determine their areas of application. Yet much of what is traditionally accepted has been either shown to be unreliable or questionable with regard to reproducibility among examiners. This is also true with motion palpation. The study we will review reevaluates 3 prior studies, each for a specific spinal region, and by combining the study's findings and through the application of a new paradigm for examiner agreement, determines if reliability for motion palpation changes. Before we review this study, what do previous studies conclude? Most studies show motion palpation to be unreliable. This is partly the result of the standard of having each examiner judge each spinal segment as a dichotomous finding, restricted or not, which means then that the examiners agree or not on each specific spinal segment. In a systematic review of 44 articles, only 8 reported high levels of reliability, with only 4 of these judged to be of acceptable quality. Other explanations include variations in motion palpation procedure, poor inter-examiner numbering of spinal levels, inaccurate markings of spinal landmarks, variations in patients' anatomy, and changes in the degree of fixation due to prior examiner's motion palpation examination. So now to the study at hand. The title of the publication is The Reliability of Spinal Motion Palpation Determination of the Location of the Stiffest Spinal Site is Influenced by Confidence Ratings, a secondary analysis of 3 studies, published in Chiropractic and Manual Therapies in 2016 by Robert Cooperstein and Morgan Young. This study is a secondary analysis of 3 published papers by the same researchers on the reliability of motion palpation. Their specific focus was on a different paradigm of reliability in spinal palpation, which involved the ability to determine stiffness using continuous data analysis instead of only restricted or not, and able to extend the range of distance that included the restriction. They measured stiffness as it relates to a vertebral equivalent, and examiner confidence was analyzed as it related to any improvement in inter-examiner reliability. Here are their previous studies on motion palpation. Note that each represents a different spinal region and that the first, on the cervical spine, included an additional author and examiner, Michael Hainline. So what is the stiffest spinal site? The researchers used mean and median absolute examiner differences, interclass correlation, and limits of agreement, which were then transformed into a vertebral equivalent. A vertebral equivalent is defined as the height or length of a typical vertebra. This allows for the difference in the height of a vertebra in different spinal regions to be accounted for, and broadens the range in which agreement can occur. We will look at the specific measurements soon. They included in their data examiner confidence and measured its influence on agreement. In essence, quote, examiner confidence may be viewed as a surrogate for spinal stiffness, unquote. In other words, the more inter-examiner agreement, the more likely this segment demonstrates more stiffness. Before we move on, an observation. This study represents a great example of how complex scientific investigation can be, so that the question as to whether motion palpation is reliable or not is an answer that depends on a number of features. For example, which motion palpation approach is being used? Which region? How experienced are the examiners? Is it valid? How accurate does it need to be? Does it make any difference in which segments cavitate? And more importantly, does it make any difference in outcomes? When testing any evaluation tool for value, there are 2 measures. Is the test valid? Is it finding what it's supposed to find? Is it compared to a gold standard, meaning a direct measure of the pathology of interest? In the context of manual medicine, this begs the question, are we looking for a subluxation or are we looking for restriction? Some would argue either or both, but with either we know there is no direct observation or gold standard to compare to, so that the only standard of comparison is what we call construct validity markers such as pain, tenderness, or asymmetry. Chiropractors have always relied on the construct validity markers of a decrease in symptomatology or a change in an exam finding. It's important to note that this study does not address validity. Secondly, is the test reliable? Consistency between examiners is called inter-examiner reliability, and with the same examiner, intra-examiner reliability. Consistency is measured two ways depending on the type of result. A Kappa value is used with dichotomous data, yes or no, present or not. An intra-class coefficient is used for continuous data such as height, weight, blood pressure, pain, or differences between examiners. So in studies that use dichotomous yes or no types of measurement, Kappa numbers are generated. The numbers can be translated into quality descriptors as it relates to the strength of agreement. Clearly, this is different from a standard testing scale. And for continuous data, as in these studies, the ICC is generated. The numbers can again be translated into quality descriptors as it relates to the strength of agreement. Note the scale is different compared to the Kappa. Unique to this study was the inclusion of the length or height of a spinal segment based on spinal region. For the cervical spine, that was 1.8 centimeters, the thoracic spine 2.3 centimeters, and the lumbar spine 4 centimeters. Evaluation did not include T1, T2, T12, or L1 due to an assumption by the researchers that these are often perceived as fixed, which would skew the exam findings towards more agreement. With regard to procedure, there were 2 to 5 minutes between examiner evaluations, and examiners were blinded to both the patient and any clinical history. Here is a graphical comparison between measuring agreement as dichotomous, moving versus fixated, compared to continuous measurement where examiner determination of fixation or stiffness is measured in centimeters, a continuous measure, and the difference is then reported and analyzed as a vertebral equivalent based on regional differences. For example, if examiner 1 finds the stiffest spinal site at the bottom or top of the vertebra, a 1.5 vertebral equivalent difference for the second examiner suggests agreement on either the motion segment above or the adjacent motion segment below. If examiner 1 finds the stiffest spinal site near the middle of the vertebra, a 1.5 vertebral equivalent difference for the second examiner suggests agreement on either the motion segment above or below. So here are the results expressed in different ways. The median absolute examiner differences for all spinal regions was 0.7 of one vertebral level. That's less than one spinal segment. So that examiners agreed on the stiffest spinal site or the motion segment, including it. 53% of the time, both examiners were confident. When both agreed in these findings, the median examiner difference decreased to 0.6 levels. Confidence then influenced agreement, so that this increased to one spinal level when one lacked confidence and 1.8 levels when both examiners lacked confidence. Reliability was greater in the cervical and lumbar spines than in the thoracic spine. Expressed in more detail, with both examiners being confident, differences were equal to or less than one vertebral equivalent in 90% of cases. In only one case did they differ by more than 1.5 vertebral equivalents. When one of the examiners lacked confidence, differences were equal to or less than one vertebral equivalent in 50% of cases. When neither examiner was confident, there were no cases where the difference was less than or equal to one vertebral equivalent. Another unique feature of this study was to run a randomly generated computer simulation. The actual information provided by motion palpation compared to simulated data improved inter-examiner reliability by a factor ranging from 1.8 times to 4.7 times, depending on the regional subset analyzed. One noted weakness was that there was a small number of subjects in subset analysis, so that only one reached the threshold of 35 subjects, which was needed for 80% power. So, as a summary, let's review what we know and what we don't know. Examiners agreed on the stiffest spinal site or the motion segment 60.2 to 77% of the time, so that they disagreed on the stiffest spinal site by more than one motion segment 23 to 39.8% of the time. The researchers observed that although it may be important to agree on what segment or segments need manipulation, it's also true that not agreeing will likely not lead to significant harm. So what we don't know is whether the stiffest spinal site represents the area in need of treatment, We don't know that if that segment is manipulated that it will change the stiffness finding, and we don't know that if the stiffness is changed whether it will change the patient's symptoms or biomechanical function. Recall, this is not a study on the validity of motion palpation, but on the reliability between examiners. It's important to use evaluation tools that are consistently interpreted by different examiners, and it's also important that whatever is being evaluated can be found with a gold standard for comparison. Assuming the results of this study are representative of diagnostic accuracy with regard to reliability, we will still need to deal with a lack of gold standard. So given this new approach to rating reliability of motion palpation may be a more clinically relevant paradigm for evaluating between-doctor agreement on what needs care, certainly the next stage is to study a group of symptomatic patients and determine if by manipulating the agreed-upon segments that this results in a better outcome for patients. Again, given there is no gold standard, our next best test for validity is patient improvement beyond that for patients who are treated without this approach. In other words, does it really make a difference?